I'm delighted to have been invited by Wound Care today to present. So I'm Sarah Gardner. I'm a clinical lead for tissue viability in Oxfordshire in the community. So we are also an integrated trust. We have mental health wards as well, but we have a massive district nursing community. And we deliver a huge training programme. We're very passionate about what we do. But we know that there are struggles trying to get that learning, that theoretical learning, actually into practice. So you've heard about the theory-practice gap. There's a lot been written on it. Nothing really evidence-wise that is specific to wound care, but we know that it is a problem generally, particularly in nursing. This is the definition of the theory-practice gap, and it's quite important, I suppose, we put a definition on it, because actually it's not very tangible. We can't feel it. It's like a metaphorical void. We know it's there, but it's difficult to measure. And sometimes when people are lacking the skills to be able to put into practice, sometimes if they don't know what they don't know what to do. So we know it's there in nursing particularly. It's probably that theory-practice gap will be apparent across all of healthcare delivery services, but we know in nursing it's there. And it can have a very negative effect on staff. And it's not just about students that struggle to put the theory into practice. It can be newly qualified nurses, but actually it can be experienced nurses who maybe have gone into a new service. So, certainly ourselves in our tissue viability team, we've had generalist nurses coming, say, from district nursing into our team, and they've come in as fairly experienced district nurses with a lot of exposure to wounds, but in fact it's a completely different ball game, isn't it, when you go into a specialist service. And it can make people feel very insecure, they lose their confidence. But it's there, and we know that we are working with nurses on a daily basis who are struggling to get their skills up to a competent level. So from a tissue viability point of view, this is me sometimes. So I've delivered my 2-day Legals course, and nurses leave the 2 days fired up, feeling, yeah, I'm really knowledgeable. It's great, I can't wait to get out there and put it all into practice. And then a couple of months later, I might get a referral, and I go and I just look at what they're doing, and I look at the nurse, and I'm thinking, but you were on my training course. I didn't teach you this. Why aren't you following what was taught? Yeah, you cannot be serious, and it's frustrating, and you've got to take deep breath, haven't you, and say, right, okay. But it is frustrating, but it's equally as frustrating for the nurses. But I think for those that are experiencing this void, it is equally as frustrating for them. But these are some of the comments that we get. I feel out of my depth. I feel very isolated or on my own. It's so difficult. So say you're trying to get them to become more competent in, say, the Doppler technique, and they start to panic because they can't hear the pulses properly. They sort of start to doubt themselves. What if I do it wrong? What are the consequences of if I do it wrong? I could harm the patient. Yeah, there's no one around to support me, and I think that is just really sad. I hear this fairly regularly, that they leave their training sessions, go back into practice, and they feel that there's not enough staff around to support them in gaining those skills. Some nurses say, well, I just copy what the last nurse put on, and by doing that, maybe I feel safer doing that. So there is problems. But we're often dealing and working alongside generalist nurses. It's all right for us as specialist nurses. We're very skilled up in what we do. District nurses, I'm talking about district nurses, I suppose we work with those that community a lot in Oxfordshire. They're multitasking. It's not just about wounds, is it? There's all the other things that they're doing which they're also expected to be competent in. And I think it helps if nurses have a particular interest. You know, they find wounds sexy, you know, it floats their boat. I think, don't you find that if actually you find something interesting, you feel a bit more passionate about it, and maybe you make more of an effort to get to that point of competence. But, you know, there's so much going on in their working day that you know, wound care is only one thing. But we know it's really important to get staff to a level of competence. You know, we have pathways and guidance that we've worked really hard in developing evidence-based tools for nurses to use. So it's really, we know that if we can apply that to a competent level, our outcomes for our patients are going to be better. So, you know, we know that we're in a situation where wound care is costing a lot of money to the NHS. And we know that, say, in district nursing, it's about 50% of a caseload can be wound care. So they're doing it a lot, so it's essential that we get our nurses to that level of competence. Nurses are out there making autonomous decisions. So if they're not competent, that's quite worrying. You know, they're the ones on a daily basis making decisions. But we know that practice is variable. And, you know, if we were to scope in this room what you're all doing, there will be some variation. And I know you can probably think of examples of that in your areas of practice. And we know that, you know, education seeks to equip nurses with the knowledge that is essential to deliver that sort of, you know, competent care. But we know that there are lots of barriers out there. And probably the one thing that comes to mind is, you know, the situation we're in with staffing levels, and the time actually to deliver the care. That's the big one, isn't it? We have to, though, you know, to improve that, you know, to consider the spend and to consider maybe the harm that patients well, we know that patients are being harmed. You know, we're using that terminology now. We have to improve the competence of the staff that we're working with. And it was interesting, Gemma saying about the nurses, sort of the whole general job satisfaction and staff morale went up when you were improving your outcomes in your service. That's really important. There's nothing better, is there, than when we know that we've done a good job and the outcomes are sound, healing rates, quality of life, pain reduction. That actually is really good for us as well, I think. We feel good about ourselves that we're able to do that for patients. So it's about staff retention and staff morale as well. So why is there this theory-practice gap? Well, we know we're working with nurses with a really diverse group of skill mix, aren't we? Are you finding in your areas there's a lot more skill mix being introduced? So historically, when I first qualified as a district nurse, we were all sort of band sixes. You know, you did the district nurse qualification and the teams were staffed by band six district nurses. And then over the years, they introduced some skill mix into band fives, and now we have the nursing associates, don't we? We have healthcare assistants, we have assistant practitioners. So if you think about it, you know, when you're trying to look at a competency framework, you've got quite a wide group of nurses in terms of their roles and responsibilities to try and address. I like this quote: wound care is everyone's job but no one's responsibility. So everyone is doing it, but sometimes we've got areas where no one takes the lead and don't take responsibility. You know, the problem around, say, primary nursing, we haven't got the luxury of that. How wonderful if we can embed that, but we know that doesn't always happen. And I'm afraid there is this ritualistic, historic practice still going on, isn't there? And unless we can break that down, it's very difficult to change and improve competency. You know, even now I hear from, say, our link nurses that they take best practice back to their teams and are still being told, well, we don't do it like that. You know, this is the way we do it here. So we have to also break that sort of culture down. And as I said earlier, it's someone's ability to know what they don't know. and how do you identify what you don't know? And we'll come on to that in a second. But also, unfortunately, going back to what I said earlier about a general lack of support for nurses at the coalface, as it were. Who here has a sort of preceptorship programme, or do they have lots of preceptors within the teams that you work with? It's encouraging to see a few hands, but not many. And even in our area, really, day to day, that doesn't happen. So nurses have to rely upon their colleagues. But if their colleagues aren't competent, you know, how is that improvement going to be made? So we've got some solutions to that maybe as we go through the presentation. Some people think that just by practicing a skill over and over again, that actually their competence will improve. Now, it might do, but I think when you consider the patients that we are working with, you know, they're not robots, are they? And sometimes you have to tailor what you're doing to actually meet the needs of your patients. So there are some skills, I think, by practicing, you will become more competent. But surely you have to still understand the theory behind that and look at it in a more holistic way. Again, reading more journals or more books or attending lots of courses doesn't necessarily result, does it, in competence? And I'm a great believer that actually you can write a really good care plan, but actually your care can be pretty rubbish. And I think, you know, you have to be able to then translate what you are producing in the way of a care plan into practice as well. And we need to be creative. You know, I loved the session yesterday with the performing medicine. You know, that is a really creative way, isn't it, about how we can learn. I learnt a lot from that. So I think, you know, we can't just, I don't know, just believe that there's only one way that you can embed learning. We have to sort of, the awful expression, think outside the box. So as I said, I'm going to share a few ideas with you, the things that we have done in Oxford. It might work for you, might not, but just gets you thinking about it, really. So first of all, I'm a great believer that to measure any change or to set a baseline, you have to apply a competency framework of some sort, okay? So I'm not sure how many of you here work alongside competency frameworks, but competency frameworks should be based on the standard expected by your organisation, by your trust for care delivery. So an example, this one I think is the management of venous and mixed etiology leg ulcers. So that competency framework will set out in a quite sort of prescriptive way what is expected by that clinician delivering that care. And what we tend to do is ask the nurses to self-assess against that framework as a baseline. Now, I don't know what about you, but I think we're sometimes not very good at self-assessment. I think we generally will underscore ourselves because we don't want to be too big-headed. But it's about, you know, just do it, get it down. And then you would share that with your mentor or your preceptor. And it could be that they say, do you know what, I've seen you in action. I think you're further along the line than this. But I think it's really important. And again, going back to, if you don't know what you don't know, this will help you find that. So always use a competency framework. Good old technology. All of our district nurses have got iPads, and they are not used properly. They leave them in the car, and they are such a valuable resource for establishing competency and a bit of a backup in terms of how things should be done. So an example, all of the tools, the assessment tools, we have things like, maybe this one on the screen here is a tool we've got for trying to identify where on the continuum of infection the wound might be. Now, if they haven't got that with them, it's not a guide that they can refer to. So we encourage nurses to download all of the tools that we've provided onto their iPads. So it could be that they're with the patient and it's a resource that they have got that they can check against. And it's just sometimes, they probably know it, but this is a backup just to sort of give them a bit more confidence. Great for photography. And that could be that they take the photograph and then take it back to base and talk to an experienced colleague about, you know, what they're seeing, just as a double check as well. They're also great for putting on things like video clips. So if it's a skill such as maybe setting up a cushion like a Roho or a Starlock, or they're not sure about the bandaging technique, they can go in and they can watch the little video clip and just check that things are being done properly. So there's a lot that you can do with things like iPads. Skype or FaceTime. If you're using this, you will need to get some consent from the patient. We ask for signed consent to be using this. And also it needs to be around user skill, how to Skype or FaceTime. And there will be some connectivity problems depending on where. We have some quite rural parts of Oxfordshire, and sometimes connectivity can be difficult. But it's a great way that when you haven't got many staff, that you could FaceTime a colleague. We have, we sort of call it telemedicine, but we do have times when if we can't synchronize our diaries, for example, with somebody we want to do a joint visit with, we will arrange to do a Skype or a FaceTime consultation. So the nurse is with the patient, and they can Skype the coordinator, and we can support them through that process. And it's just really a good way of that confidence boost. You know, that it's a way of acknowledging that what they're doing is correct, just double checking really. And as I said, it's really good when staffing levels are tight and that you can't get a buddy to go with you. Recording a consultation, some people cringe at this and think, oh my goodness, no, I can't bear seeing myself, you know, on a film or whatever. But it could be an audio, they could just record it that way, or they could record it. And we would do that with our iPads, and again, you would need to get patient consent for that. And this is a good way of some self-reflection, but also that you would sit maybe with your preceptor or your mentor or your buddy, and you would go through the recording of that consultation. It's a good way also of checking things like your communication skills, your interpersonal skills, as I said, your assessment skills. And sometimes when you're watching yourself, you just think, really? Did I really say that? Or, you know, it's great for sort of looking at body language and that sort of thing. So that it's just one way. As I said, we have used that before. OSCE type scenarios, I think student nurses are very used to this. We don't do a lot of it once we're qualified. And it's a good way to do it as a team. So, you know, just to get some protected time, I don't know, 15, 20 minutes sort of at lunchtime. Or it's great to do it with things like people like your link nurses. So it could be this is where we're doing some wound measurement, or it could be a new standard that you're going through. We recently produced a new dressing procedure on the back of an incident we had with wound infection. We felt that things had got a bit sloppy in the old hand hygiene and the whole process of dressing a wound. And it's just a good way, really, that someone could perform the procedure with the team, your peers being there offering support and making sure that all of the points have been covered. You know, it can be done for bandaging, for Dopplering, or wound measurement, for example. Role play. Oh, God, blimey. I have these awful memories when I did my mental health stint in my general training, and all of us sitting there with arms folded, you know, thinking, oh, we really hate this. Some people love it, but again, it's a good way of sort of practicing skills in maybe motivational interviewing. You know, when you're trying to look at the patient's readiness to change, or again, those interpersonal skills or communication skills. it really pushes people out of their comfort zones. So it has to be done in a fairly safe, unthreatening environment and sort of an agreement as a team. Just another thing in the toolkit really for people to try. You could develop a skills lab. We have a skills lab in Oxford, and we got that funded through charitable funds, because there's never any money in the budget, is there, to do these things. So this is where it's being kitted out for lots of other things, but there are plenty to do with wound care as well. So there'll be Doppler machines, and they've got the false bottom and false leg, and there's, you know, bandaging and wound measurement and stuff. And you can book that out, so it's a nicer, you know, quiet environment away from the phones ringing. And you could go in there with a mentor or a preceptor or one of the clinical trainers and practice those skills. Things like a case study review or clinical supervision. And that's quite a good way of checking. So a nurse has been out in practice, and they would draw a set of notes back, and they would come and you dissect it really. And you've got your peers who will maybe question you, and in a non-threatening, challenging way, a constructive way, to ensure they would question the decision making. Why did you do that? Why didn't you consider that? Have you considered the other? And you would ensure then that, you know, that the guidelines or standards are being adhered to as well. You could use a reflective tool or a reflective cycle to go through that if you want to formalise that process. And the good thing, I think, what needs to come out of it, there has to be learning, and that we would encourage that there should be at least 1 or 2 action points on the back of that which need to be moved forward. And that's really important, because learning won't be embedded unless there's some sort of action points that you all move forward as a team. Good old link nurses, we have a team of what we call our tissue viability resource nurses. This is them when we were doing Stop the Pressure Day, or wound care champions. And they are brilliant as your mini experts out in practice. And it's the link nurses who should be that first point of contact for nurses who need that extra support and development. And again, you know, it's one of these things that it's easier said than done, because even though we try to protect some time for our resource nurses, when push comes to shove and you've got staff vacancies or sickness, you've got 2 patients needing a syringe driver, what's going to happen? You know, they'll be diverted to do that. But there needs to be a priority placed on this role, because they offer so much to the nursing teams in terms of skill development. You have to do the best, and we have to sort of lobby for them as such an essential role. Handover huddles. So these are really good in that it's a very quick way of ensuring that everything that should have been done has been done. We use patient status at a glance. I don't know if you've heard of it. This is the board here, and this is around a leg ulcer pathway. So you would come back at an agreed time, and you would have a handover huddle where, as a team, you are going through, right, we've got this patient with a leg ulcer. Has a lower limb assessment been done? If not, has it been scheduled? You know, have you allocated them onto a pathway? Have you measured the wound? Is there a surface area reduction? So it's a bit of a checklist about, you know, best practice again and whether it's been put in place. Take 5 audits. I think this is quite a powerful way of ensuring that best practice has been embedded. So we would say that you agree a time, it could be quarterly, that the team would bring 5 sets of notes which would be applied to a audit framework. So if it's, say it's around wound care, you would have an audit tool. Has there been an assessment completed? You know, has the wound been measured? Is there a care plan in place? You would just double check to make sure everything that should have been done has been done. But again, there might be themes that go through that audit where there's something that's not being done consistently. So as a team, you would say, well, why is it that wound measurement isn't being done? And you identify as a team that it's because actually you've got a bit rusty and you need some teaching around that. So it's a good way of identifying where there are gaps in learning, and you can then put an action plan in place to improve that. And working with industry, we can't forget working with industry. They are a valuable partner in providing education and support to our workforce. But I would really urge, and I think most of the companies that are doing this now, this is not about sales, this is about education. So any working with industry has to have that focus. And they are really creative, and they can think of creative ways to supporting you, doing some bespoke, sort of tailoring it to your workforce. There's a lot of e-learning modules now that are being produced, which is a great way of improving competence. But you need to be working with them to set out the brief about what you want to achieve. And they are really an invaluable resource. A lot of the companies have clinical trainers now or specialist nurses to support that role as well. So please do utilise our industry colleagues as well. So in summary, the gap between learning and practice is forever present. I don't think it'll ever go away, but we have to manage it. We have to do something to try and close that gap. It's essential that anyone starting in a role needs good support. So there needs to be some sort of buddy system or preceptorship to ensure that nurses feel valued and they start to feel more confident about the practice that they're delivering. Teams do need to be creative. I've only given you a few ideas today, but do take those back. But we need to think a bit widely about, if you've got gaps, what is the solution to that? And involve everybody. It's not about just us as individuals deciding that. Draw on some resources, have a focus group or something, but get ideas from wider. And it's not a one-off, is it? We need to think about how, when nurses are competent, we can sustain that. And that's the difficult bit, isn't it? Keeping it on your radar. So it needs to be a long-term plan, not just a quick fix and then it's sorted. We need to sustain this. And make learning fun. I think the more fun it is, people do learn better, don't they? So an example was the work yesterday with the apps like Amdram, isn't it? It was fun, even though there was a serious message being delivered. So thank you, and if I could be so bold as to also piggyback on the back of this, in another role, I'm a trustee for the Tissue Viability Society, and I just was asked if I could pop this slide onto my final one, just to advertise that we also have a conference which is being held on the 1st and 2nd of May down in Southampton, and we'd love to see you there. So thank you very much for listening. Thank you.